This is a side-by-side comparison of a healthy human brain and a brain in the late stages of Alzheimer's disease. Notice the widened cortical sulci, the shrunken gyri, and the severe atrophy of the hippocampus. Alzheimer's is a progressive neurodegenerative disorder, accounting for 60 to 70% of all dementia cases globally. This specific structural loss in the hippocampus drives the disease's primary clinical manifestation, severe memory impairment. As tissue degradation advances, patients also experience aphasia, a loss of language skills, and a complete breakdown of executive function. Because the pathology features massive, irreversible neuronal death and heavily documented genetic risk factors, Alzheimer's is widely perceived in medicine as a biological inevitability. New epidemiological data challenges that exact premise. In 2024, the Lancet Commission on Dementia Prevention published an update that reframes our understanding of the disease's trajectory. Their primary finding, 45% of all global dementia cases are potentially preventable or can be significantly delayed. This reduction is achieved by actively targeting exactly 14 modifiable life course risk factors. The updated 2024 model incorporates two newly identified targets into this list: elevated LDL cholesterol and failing eyesight. To understand how environmental variables delay a genetically driven, physically destructive disease, we must map the molecular cascade of Alzheimer's itself. Only then can we identify exactly where these 14 lifestyle variables intercept the pathology. Let's scale down to the microscopic level, to the cellular membrane of a single neuron. Embedded here is the amyloid precursor protein, or APP. Under normal conditions, this protein penetrates the cell membrane and assists in neuronal growth and post-injury repair. In Alzheimer's, gamma and beta secretases divide the APP protein into fragments known as amyloid beta 42. These misfold and self-assemble outside the neuron into toxic oligomers. Eventually, they expand into dense, insoluble amyloid plaques, severely disrupting normal cellular function. That is the extracellular damage. Inside the neuron, a secondary mechanism fails within the cell's microtubule transport system. Neurons rely on an internal network of microtubules to guide nutrients from the cell body down the axon. A protein called tau acts as the structural tie, stabilizing these microscopic tracks. In Alzheimer's, tau becomes hyperphosphorylated, causing it to chemically decouple from the microtubules. Without tau, the nutrient transport tracks disintegrate. Free-floating, these detached tau proteins pair with other threads, twisting together into dense, dark masses known as neurofibrillary tangles. This dual accumulation, extracellular amyloid plaques and intracellular tau tangles, destroys synaptic connectivity and inevitably drives the neuron into irreversible apoptosis, or cell death. While this dual protein pathology is the universal signature of Alzheimer's, the biological trigger that initiates the cascade varies drastically between patients. Only 1 to 2% of all cases are classified as early-onset familial Alzheimer's disease. This map isolates the specific autosomal dominant mutations responsible for those early-onset cases. They occur in the genes encoding the amyloid precursor protein, as well as presenilin 1 and presenilin 2. These specific deterministic mutations directly increase the sheer volume of A-beta 42 produced in the brain. The vast majority of patients develop sporadic, late-onset Alzheimer's, yet this sporadic form remains up to 70% heritable. The primary genetic risk factor for these sporadic cases is an allele of the apolipoprotein E gene, known as APOE epsilon 4. Unlike the deterministic genes that overproduce amyloid, the APOE epsilon 4 allele disrupts the brain's waste removal system. It causes highly inefficient astrocytic clearance of amyloid beta, leading to a gradual, age-related accumulation. For most patients, genetics dictate the baseline rate of protein clearance. Clinical dementia is a biological vulnerability, not an absolute molecular certainty. If genetics dictate the internal rate of amyloid clearance, environmental factors dictate the brain's systemic resilience to that damage. This introduces the concept of cognitive reserve. Experiences early in life dictate the physical efficiency of neural pathways. This is the Lancet's 2024 life course risk chart. In the early life phase, less education is a primary risk factor. Higher education and occupational attainment physically build denser, more efficient neural networks. A high cognitive reserve acts as a buffer. It allows a patient to maintain normal cognitive function and delay clinical symptoms even as amyloid beta silently accumulates. Moving into midlife, the focus shifts to vascular health and the maintenance of the blood-brain barrier. The chart expands here to show how hypertension, smoking, and elevated LDL cholesterol physically disrupt cerebrovascular integrity and increase oxidative stress. This vascular damage accelerates neuroinflammation. When plaques do form, this compromised environment significantly lowers the threshold for neuronal death. In late life, the risk profile centers on how the brain manages sensory input and environmental engagement. The completed chart incorporates the newly added 2024 risk factors, late life vision loss and hearing loss, alongside social isolation and air pollution. When a person loses vision or hearing, the brain's cognitive load drastically increases just to process basic external stimuli. This sensory deprivation accelerates structural atrophy in regions already vulnerable to protein buildup. These 14 life course factors act as compounding subclinical insults. Mitigating them actively shields the brain, separating the presence of genetic Alzheimer's pathology from the clinical manifestation of dementia. There is a timeline paradox in Alzheimer's disease. The clinical diagnosis is vastly out of sync with the biological reality. This graph illustrates the 30-year progression of the disease. The complex degenerative mechanisms, specifically A-beta oligomerization and microglial inflammation, are active in the brain for decades before the first symptoms of mild cognitive impairment appear. The red line tracks this silent biomarker accumulation. Meanwhile, the blue line, representing clinical cognitive function, remains completely stable for 25 years, dropping sharply only at the very end of this massive subclinical buildup. Current pharmaceutical interventions, specifically FDA-approved monoclonal antibodies like lecanemab, target and clear amyloid beta. But because the pathology is deeply entrenched by the time symptoms arise, these drugs offer a statistically significant but clinically modest slowing of the disease. They do not reverse dementia. Intervening at this late stage also carries severe adverse risks, including amyloid-related imaging abnormalities, or ARIA. Contrast that late-stage pharmacological approach with the 14 Lancet life course interventions. These intercept the pathology continuously across the entire 30-year timeline, depressing the total accumulation of biomarkers. The most potent tool in modern neurology is not late-stage pharmacological reversal, but life course primary prevention. By managing risk factors from youth to old age, we mitigate neuroinflammation, build cognitive reserve, and effectively delay the clinical onset of Alzheimer's disease beyond the average human lifespan.